going on. All we want is this has to be moved a little bit front and back based upon who is shouting.
Yeah.
Thank you.
We're going to treat this as a microphone, just so because we're recording everything, so just pass it along.
And they're actually going to talk us through all the cases and get us involved in decision making. So
give us 1 minute. The guys from India are trying to fix up.
So we are also relaying this MDT
I'll set it down.
to a center in India. It's being telecast or Zoom live. So we'll just wait for a few minutes.
Mr. Prakash, we have got Professor joining us as well.
That's even more exciting.
Yes, big more exciting.
Yeah, that's fine. So morning everyone. So as Mr. Galach says, we'll be presenting the cases for our expert panel to discuss the Gemini training in the region. Just before we kick off, I just want to say, acknowledge and thank all the units that have provided cases for us. There was an abundance of really complex and challenging cases from across the region. And unfortunately, of course, we can't use time constraints to discuss every single one. We've tried to select out cases that kind of illustrate some of the key topics and themes we've sort of touched on in the morning, and hopefully stimulate some interesting debate and discussion for our panel. So, and we've tried to kind of include cases from most centres in the region to be representative. So, Michael and Jeremy.
Thanks. So thank you everyone for coming. Thank you for those that have given us calls already. I think we're going to try and pull out some of the points that we've already discussed. So, moving on to our first case. This is a 24-year-old young lady. That's right. Otherwise fit and well. Normal renal function. She underwent an MRI of her abdomen for some abdominal trouble, which has incidentally detected a renal cyst. Let's get it highlighted for you. In order to get some sort of further characterization, she then also underwent an ultrasound scan, which has shown vascularity within the lesion and was very suspicious for a neoplasm. So, question to our MDT panel. Mr. Chakravarti, what do you think the role of biopsy is in this case?
What is the size of the tube?
It's smaller,
And she's 24.
24, fit well.
I would certainly put it to the patient. That remains a valid choice during counseling. So I would certainly put it to the patient that there is a role for biopsy. Whether she takes it or she opts for upfront surgery is her choice. So that's my usual practice.
Any other opinions from the panel?
I wanted to see more of the imaging actually, because I think I think there is a risk that it's quite cystic, in which case the biopsy is not a good idea.
What would you like to know more from?
How cystic is it? Because it looks to me like it might be quite cystic.
So I think
It's
that in
enhancing.
this particular case, the ultrasound actually did say that it was a solid thing. It was
Okay.
not cystic. Our radiologist showed us with convincing evidence in the meeting that it was a solid thing, not a cystic.
So the options were put to the patient for biopsy or for primary intervention or for nothing, surveillance. She opted to go for a biopsy. The biopsy confirmed the presence of clear cell RCC, grade group 1 to 2. What would be the sort of most appropriate management in this patient, Dr. Hannes? She's very young. Do you think ablation would be an option?
As a lesion, yes. As a patient, I would probably defer to my surgical colleagues first to make a decision. Because with a younger patient, even if you consider ablation, so as a technique with that size, we feel, yep, I can get there. I can stick a needle in there. I can burn it or freeze it. But then what follows is the imaging follow-up. So in 24-year-old, you're going to subject this patient to repeated scans. If there's a recurrence, then you're going to have even more scans. As opposed to if there is a surgical option which can take care of this with a good safety profile in a low complication way, then I'll first ask the surgeon. That might be the better, longer term option.
You're still going to do the same follow-up.
With imaging, would you?
Yeah.
Is it 5-year annual follow-up? Is that what
She's
you do?
24. She's going to get more tumours potentially.
Okay. Then in which case, I would be happy to put ablation on the table in that case.
Anybody else think that's better
I
management?
wouldn't do anything for a start other than refer her to her geneticist. I want to know exactly what predisposed this tumor and have some prediction of how likely it is that she will have more tumors in the future. This very small tumor, I'll wait a little bit till I know more. I know now it's cancer. Well, I don't know whether it's indolent cancer or it's an aggressive cancer. And I think its behavior over a short period of time with repeated imaging, ultrasound will be more than enough. And see, it's not how much bigger it became, it's how many increments of increase in size are happening over the next year or two. Because there is mounting evidence that it's not how much bigger it became, but whether it's becoming bigger every time you measure it. And that will allow us to make a plan over her lifetime, because she's in trouble.
I think we're all getting excited about this case.
Yeah, well, we've already learned earlier on that there's not strong concordance with biopsy grade, and so I'm uncomfortable with watching it with by labeling this as a low-grade tumor in such a young lady. We also know that tumors, it's less than 2% metastatic rate per year with this size, but that's a disaster in a 24-year-old lady. And finally, we mustn't forget that she needs to be encouraged to refer herself to the genetics team as well.
So that's great. So all of those options were put to her. Sorry.
Yeah, another point I would like to make is if you intervene early, I see a point in what Adele is saying, and there is certainly a point, but you got to make this, you got to keep this in mind, that if you wait for the tumor to get bigger and then you resect, you lose more renal mass. So our aim here is renal preservation as well, and achieve a proper oncological outcome.
And also it could be both multifocal, as we have gone, and it may be bilateral.
Yeah.
So preservation of renal tissue also becomes a very important, somebody so young.
We will cover some of such cases shortly.
I was going to intervene for a minute. I'm going to take it back to the biopsy stage and get a view from all of you. Mr. Bakar, would you have biopsied?
If it's solid, I would have done in this.
It was solid.
Yes.
You would have biopsied. Tony,
I would have offered it with Chris's provisos.
you would offer it. Okay, Rupesh,
I would have offered it, but I would have probably moved to
offer it.
treatment.
Looking at a snapshot picture, I would have been happy to do the biopsy because there's quite a bit of solid elements.
I
to
would
it.
have definitely offered the biopsy for her.
Absolutely.
So panel wants to biopsy. Last question I want to say, what would panel do if it was negative?
Monitor with imaging.
Monitor imaging.
I think same.
Agreed.
So we have concordance with
It's a unique moment.
So often her biopsy was probably incomplete.
This morning, Mr. Bharat was mentioning about rebiopsy. Will anyone consider rebiopsy?
Not if it doesn't grow.
I'm talking about immediate rebiopsy. I think that's the procedure.
I didn't think he meant immediate biopsy.
We'll wait and see for some time.
Nobody does.
It all depends what the non-diagnosis is. Is it normal renal parenchyma? So is it a technical issue, or is it a real non-diagnostic?
If you look at his flow chart, if I got it right, he said there was a period of surveillance. If they grew, then they will rebiopsy. If they stayed the same, that's what I understood from the flow chart. Somebody outside the mouth,
Mr. Bhatt, like you said, if it's real non-diagnosis, would you then do an immediate rebiopsy, or would you wait for repeat imaging and then opt for rebiopsy?
So I mean, all of this, and like with all most of the stuff, is about your counselling with the patient, really. Yeah. So even before the biopsy, the first biopsy, the counselling is you have to tell them that you're 80% chance of getting a diagnosis, but they've got to know the difference between a positive predictive value and a negative predictive value. Okay, that's really vital. So what I don't want patients to go in when they get a biopsy is thinking that if the biopsy is negative, they have not got cancer. And once you fall down that hole, then you're in trouble because you're always stepping back from it. So it's about the counselling. And I probably, in this case, if one biopsy is negative, I'd probably, as we've agreed, do a serial scan, and if they're keen on a biopsy, do one sequentially at 6 months, for example.
Okay, good.
So she then went on to have, oh, sorry.
What's the risk of metastasis for a 2 centimeter lump in a 24-year-old girl?
Less than 1%.
In a 24-year-old?
Well, it's about the size rather than about
It's the size, not the age.
It'll stay for a long time for her.
I guess that's if it stays less than 2 centimeters.
That's a very high risk for a 24-year-old who's got a 2-year-old daughter.
Yes, it is.
Absolutely very high risk, yeah.
It is.
Also,
I'm
if
trying to
I remember
think-
correctly, 11.9% of under 3 centimeter tumors can be high grade.
True.
Well, you know, we get the natural history from Jewett's paper, don't we? And I'm trying to think what the lowest age was in that. Off the top of my head, I don't know what it is, but I'd be astonished if it's 24.
It was not young as this. It's
Yeah,
slightly
I'd
older.
be astonished
Yeah,
if it's
slightly
24.
older. Yeah.
From Jewett's paper, which is where we get all of this from.
Yep.
Okay. So this lady went on to have a robotic prostatectomy, confirmed G2 tumour with negative margins. Postoperatively, her GFR remained over 90. She was very well.
Fantastic.
Came very well.
So it's a slightly different situation with this. So it's a 66-year-old, but he's got a few comorbidities, some mental health issues, performance data being 1 and 2, and he's got it's a cystic lesion, so Bosniak 4 cyst, and that's the MRI. So it's in the upper pole, lying immediately 2.7 centimeters. First question to the panel is there any role for biopsy in this patient? Is it amenable, and focal therapy, does that have any role in this? Maybe Dr. Fulkardis can.
Okay, so obviously, based on the cross-sectional imaging, you've already gone down the route of classifying it on the Bosniak scale as a cyst, or the Bosniak 4 cyst, meaning that you already got some numbers you can give a patient what the malignancy risk is for that particular kind of a lesion. Yes, you can attempt a biopsy. Technically, you can try there, but obviously, as we've discussed, the chances of getting a true lesional sample gets lower and lower. So if you can imagine, while the lesion may be 2.7 centimeter, the solid component is really that bit at the top that you can see. The bulk of it is cystic fluid. You could send the fluid off for analysis, but again, the chances of getting any positive cytology gets lesser and lesser. If a patient has had a Bosniak 3 or 4 cyst and they've gone down the path that they want to have it treated, then I don't regularly offer biopsy. I say I could try it if you want me to, but your chances of malignancy have already been explained to you with what the grade of the cyst is, and we could go in there and treat it as it is. Because that in our practice is a better way to go about it. We end up spending more time and causing more anxiety doing biopsies with little positive value when you have a cystic component as much as that is.
And focal therapy, would this be?
It would be amenable. It is a well demarcated lesion in a position that we are able to get to. Size wise, you can offer cryo, microwave, both of them. So yeah, we are in a position to offer focal therapy in this case.
Are you happy to do focal in cystic lesions?
We are. What we found is that they just evaporate more than scar. The cystic component and the solid component scars like it would. So if you're able to get in there, one clean needle for this size, one microwave needle will be enough to achieve the ablation zone. You can get in there, yes, it does work. Cryo, less so. So if you had a cystic lesion that is getting bigger, say close to more than 3 centimeters, we give the patient less optimistic chances of getting good. Cryo doesn't freeze as much as in a part cystic lesion, but microwave burns it quite well, really.
What about RF in this?
So both. So heat based would happen. So microwave, I mean heat based. So whether RFA or microwave, if it's a mostly cystic lesion or part cystic lesion, it works fairly well. Yeah.
No, you're right. Even in the laparoscopic cryo, for when they got a cystic component, the cystic component kind of stays there all the time. That's all it gets, scar tissue, but the cystic looks as nothing has been done to it.
One thing I have tried when you had a slightly bigger lesion, more than 3 centimeter, which had a cystic component, was to get in there with a spinal needle, aspirate the cystic component rather than letting it rupture and spill all over the perinephric space. And then what you're left with is a much more collapsed lesion, which you can then, mostly solid now, and you can then go and ablate.
Question to ask really, I appreciate we haven't got all the imaging for you to evaluate this, but does this often happen in your MDTs where you say, is this lesion easy to biopsy because of the place where it is this lesion amenable to ablation, and you document that before you actually see the patient when you're offering the options? Does that happen in every MDT?
I'm sure it does.
We stay technically amenable, don't we?
Yeah, exactly. So we set up a protocol. We have set up a protocol about these ablative, about these small renal masses, and the questions for that the MDT has to answer in that case is, we ask, Salil and Ian's help is just that. Can it be biopsied, and is it technically feasible? Whether it should be done, that's a discussion, in clinic with the patient. But yeah, you need to have that information before it goes ahead, and it's put into Somerset.
This means interventional radiologists should be present in every MDT.
Yeah,
Absolutely.
That's the national
Absolutely.
requirement, but it doesn't
Yeah.
happen that way.
Otherwise, we can't make a decision.
But the ablationist should be there.
And also the other problem is that in smaller hospitals where you don't have that many interventional radiologists for every MDM, so the person who makes the decision says something, and then the real interventional radiologist might say, I can't do it.
Exactly.
So that's a frequent problem that happens sometimes as well. So that's also a valid point.
Okay, so based on same thing, shall we have a real biopsy?
Absolutely not.
Tony?
And I think it's contraindicated in cystic tumors.
Yeah.
One of the problems that are very underreported in biopsies is the seeding, and cystic tumors are associated with a higher risk of seeding for obvious reasons. And most cystic tumors are actually type 2 papillary renal cell carcinoma. And these are very aggressive tumors, and if you seed them, it's disaster. Anecdotes are only anecdotes, but literally yesterday, I operated on a kidney mass after a biopsy, and between the time of the biopsy and the operation was about 6 or 8 weeks, and it was inoperable, completely contrary to the CT scan only a few weeks before. Eventually, we took it out, but there was lots of lymph nodes that weren't there. How much of that is from the biopsy, I don't know, but cystic lesions for me is a contraindication for biopsy.
Tony?
2.7 centimetre in a comorbid patient, I wouldn't biopsy, I'd surveil.
So no biopsy to patient?
Yeah, I probably wouldn't biopsy this particular one.
You wouldn't?
Probably wouldn't, no.
Wouldn't.
I wouldn't. Same there. I'll agree with
I
that.
wouldn't. Yeah.
On it?
It's a
No,
no.
I don't.
No.
So the panel is not for biopsy for this particular patient?
Interestingly, they had a biopsy. They had another biopsy and didn't yield a huge amount of information, and then had a failed RFA attempt.
Sorry, can I correct you on
Yeah,
this?
go on. Can we go back to?
If I could divulge, this is one of my cases. This came from another center. So all this happened in the other center before the case reached me. So it wasn't just a biopsy. They attempted two RFAs.
Right.
And during the RFAs, they tried to biopsy.
So if we go back to this, the MDT here is recommending not a biopsy. It's really a very important point to document that the MDT is recommending no biopsy. So when we are counseling the patient, we should say, well, we do not know what it is, as we all say. It could be this, it could be that. Well, unfortunately, we do not recommend biopsy either. So it's clear to the patient that actually...
There's a difference between not recommending a biopsy and recommending no biopsy. That's different. Recommending no biopsy, which is what you said, is not the same as not recommending a biopsy. The patient can still say, I need to know what this is. He's got psychiatric issues. I need to know what this is before I can get my head around what I'm having treated. And they could twist your arm.
Well, that's what MDT stand for. Yeah.
Recommendations.
Our MDT recommends that we don't do a biopsy. Yeah, and I think that's where the power of MDT comes. That this is a panel of members who are experts in dealing with this, and we are not recommending this. That's where you stop getting arm twisted, isn't it?
Yeah.
Isn't that why MDT exists? Well, that's what I use it for.
Yeah, that's a difficult one.
That's what
Difficult.
it is for. Yeah.
It is difficult. And the MDT doesn't have the patient details.
No, it doesn't, but it
So-
does help you to give you some tools
Yeah.
to actually implement what you think might be right for a patient. Obviously, taking counseling into consideration, taking choice into consideration. So yeah, biopsies happen, but for whatever reasons.
But these aren't biopsies then, aren't you, from what you said, Arnie? These are treatments that had a biopsy at the time.
Yeah.
So I wouldn't class these as biopsies.
So, as Mr. Chakrabarty said, had failed RFA, time of biopsy. So at this point, what would the MDT suggest for this patient?
Continuous surveillance.
Surveillance,
I don't know the host factors very well, sorry. If
So-
he's not well,
Very, very forward.
Yeah.
I'll leave him alone. to
I
be
will leave
honest.
him alone.
I'll say symptomatic treatment only.
surveillance. I think
Surveillance.
I think the
No,
panel member
no,
are.
there's no point in surveillance. He's not fit. It's symptomatic treatment. Come back if you bleed or if you have pain.
Rule for
I wouldn't image him again.
I think active surveillance obviously depends on. I think it's not like a basket where all comorbid patient with comorbidities have the same kind of issue. So obviously this gentleman was 67, wasn't it? So
Yes.
people may have different comorbidities, and so it needs to be assessed for homocysteine. And after a period of surveillance, if this tumor grows and there is a radiological suspicion this is still a cancer, it depends on what active surveillance, what is the rate. But at this stage, 2.7 centimeter, I wouldn't treat it. Only if it grows rapidly, then Saber would be one of the options.
I thought you wanted a positive biopsy test.
Yes, we can attempt.
We haven't got
biopsy.
that.
No, but if it grows, so at this time point, I'm not recommending biopsy. But it becomes 4 centimeter, like I showed 2 cases where tumor increased from 2.8 to 4.4, then had a biopsy. So at this point, I wouldn't recommend biopsy because this patient has comorbidities. But at some point, if the tumor has grown and it's a suspicion it's a cancer, and not the cyst, because all cysts grow, it's the solid component. If it's grown, then you can attempt biopsy, and if that confirms, then you can offer Saber.
Another thing I have found struggle with, and I would be interested in the panel members, that often these people, if we say there is nothing more we're going to do, they feel abandoned, and they like this reassurance of having a surveillance scan, whether it makes a difference to management or not. Do you guys come across similar problems?
Yes. I mean, this patient also has got psychiatric issues, as was mentioned.
Yeah.
Sometimes we completely saying we don't follow you up anymore may have a greater impact. At least some people don't want anything, but still they want to be followed up. I think we have to make the patient happy as well, and equally, what do we lose? We do hundreds of scans. We do another scan basically.
It looks like the panel is settling for either doing nothing or surveillance.
Surveillance,
Yeah, is that correct?
Yeah, that's what I think. But what other members of the panel say?
Yeah, well, exactly. I would. My worry about that is that if you see somebody else the next time round,
Yeah.
then you go through the whole circle of biopsy. Should he have an operation? So I think you need to as the lead clinician make the decision, set the path, and I think the path is, as Tony's implying, probably discharge, isn't it? Or Adele's implying discharge. If you're not going to do anything, you make a decision now. You've got all the information you need. You've got your patient with you, and then you counsel them appropriately, and then that's your final decision. Things may change in the future, but that's my thoughts.
That's a more a black and white situation, isn't it? It's not always applicable because this patient is 66, and there is a long time left for the patient.
The only way you know it's changing is if you follow it up.
He's only
Yeah.
going to get more unfit. He's not going to get
Okay.
better.
And now
He
we
was
have-
he was not unfit for the
procedure.
If you list ischemic heart disease, diabetes,
what is
hypertension,
the issue?
all that, but that has a degree of things. That patient may not be fit for partial
Stop,
nephrectomy,
stop.
but he may be fit for ablation or
Yeah,
Saber. I mean, there are patients that, because especially for a 68, I can understand somebody's 84. Yes, somebody's 67. I think 30% population has hypertension, diabetes, and ischemic heart disease. So we can't. So I think just how you put it to the patient. If you say, look, this is less
information that's missing, performance status.
Performance status is 1 to 2.
So two.
1 to 2.
1 to 2.
So the key, we get a lot of these high-risk cases referred to us at the QE, and so our protocol, and Salil knows as well, is that, and Hossam, that they get an anaesthetic opinion for, not just a general anaesthetic opinion, are you, well or not well, are you fit for a partial, are you fit for ablation? And, they get a formal consultant anaesthetic opinion, then it's in writing. We've had a recent one of these where we've had to do 2 anaesthetic opinions 6-9 months apart.
So I think if somebody needs treatment just to the whole, urology community, and they're not, if they're not fit but they need treatment, there is saver an option.
Okay, all right.
We couldn't even decide on what performance status is like. He's one strict.
That's what happens in MDT exams.
It's a very, very interesting case actually, because it just highlighted the dilemma why cohorting these patients in an MDT is not possible.
True.
Because there is no, in kidney cases in particular, there is no index patient that you can follow for a group of patients. Every patient is peculiar. Performance status, overall renal function, type of the tumor, type of the treatment available, and unfortunately our workload is going up and up and up in one direction only. And they are difficult, and every decision has to be individualized.
I couldn't agree more.
Yeah, that's absolutely correct.
Is there a question in the audience?
Just about follow-up of patients in terms of scanning. Is there a role for dedicated neuroradiologists to more actively on
Sorry, I didn't quite get the question correct.
Is there a role for a dedicated uroradiologist to be reporting these scans for follow-up?
I think in an ideal world, yes.
Yes.
But, I don't think whether it's possible in every unit. I don't know what other members
No,
are.
it is difficult.
For that to happen, we have to wait several years, I think.
We've got AI coming up.
Good one for it.
Yeah, it's ideal for one person to look at the same scan to compare everything, but I think it's very difficult to obtain in practice.
That's part of our protocol at the QE, that uroradiologists should report, these scans, and yet I know even at the QE we're not managing it. And we've got all the resources, we've got the best resources in the region. So
Can I ask the panelists, what do you do? Because one of my bugbears in the MDT is a radiologist who is not a uroradiologist. And it's a simple cyst to the blind, you can see it's a simple cyst. And at the end, at the bottom of the report, he or she will put an MDT discussion, a urology MDT discussion is suggested. And once he or she has put this,
That's it.
there is no other way other than putting him on the MDT. And then we find ourselves sat on a Friday evening at 7:30, still going on patient number 98 to discuss a simple cyst. How can you deal with this in your MDT?
We'll talk about that lunchtime.
Is he hangry?
Drives me insane.
So the question you're posing is a Bosnia 1 cyst listed on MDT. Yeah, is that what you're saying?
Yeah.
Yeah. Well, we'll talk about that lunchtime.
Let's move.
Let's move.
But if it's in black and white in writing, discussing the MDT, and you don't discuss in the MDT, 10 years later you will be in prison. If he develops another tumor.
Some units have benign MDT.
So if you want, how we have weeded this out is our MDT coordinator looks at Bosniak 1, Bosniak 2 cyst. She has a standing instruction.
But they don't put Bosniak 1 or 2. They say
2F.
lesion.
Yeah.
They're not specialists.
So the way we've got a formal indication for what comes to the MDT, and these ones are the unclassified ones, unless they've had a formal renal mass characterization cyst and they've been reviewed by a uroradiologist, it's back to the referring team. They don't get onto the MDT unless they've had formal characterization cyst. That still doesn't give you the answer.
I totally understand what you're saying. But we'll talk about more of that next time because we won't be able to finish our case.
Yeah.
So let's move on for the sake of time.
So ultimately they were managed medically with a partial nephrectomy. It was G3 T1A with negative margins.
Sorry, did you have an open robotic?
Robotic partial nephrectomy.
Robotic.
partial radical?
Partial.
Thank you. So just to point out that point from Mr. Rajab, the information, all the information that we've got about all the patients is provided. So if we don't have the information, apologies. The third case is a 70-year-old gentleman. He had an ultrasound scan due to AKI after TRP, which incidentally found bilateral complex renal cysts. He's got part of the history there, formal status is 0 ASH2. He had a characterization CT, so we make it to your MDT, which showed bilateral Bosniak 4 cysts. And what we're interested in is there a role for biopsy here in these bilateral cysts?
Do you want more pictures? Do you want is
I think
a solid
Sajid
element?
will ask for more pictures. I suspect.
I would, but let's assume that all that has happened and that we've finally classified them as bilateral Bosniak 4 cysts. And again, for sake of uniformity, I'd maintain the same opinion. Is that it all really depends on the Bosniak 4 cyst depends on the extent or the degree of solid component versus cystic component. If you have 80% is now solid for whatever reason, then there you go. That's that. Yeah. Still doesn't answer, but that's fine. Okay, but the point is that for uniformity, I would still say if it's a primarily cystic lesion, I wouldn't jump in and offer a biopsy.
Anybody else would offer a biopsy?
I think we kind of established that in the last
Yeah, in the last
discussion.
discussion,
That's
yeah.
the stake. We are all a bit skeptic about biopsy.
Yeah.
The MDT agreed. So patient underwent or planned for bilateral partial correctomy, the right side first. The right-sided lesion was found to be an oncocytoma.
Right.
Do you think now there's a role for biopsy the left side?
Just
Could
wait.
I go one step back? Would all the panel members have chosen to do this? Bilateral partial? Yeah? Bosniak 4?
I would say the right side would have chosen to do a robotic partial. The left side would wait and see.
That's what I've done. I've done the right side. And my question to the panel, what do you do with the left side?
I think all the more we wait now because of the oncocytoma on the right
Yes.
side.
It doesn't change whether you're getting bilateral oncocytomas or
How many
common.
times
So,
have you seen a
RCTs.
cystic oncocytoma? And how much do you believe the other side is a cystic oncocytoma as well? What do you do?
I actually don't think whether it's cancer or not matters at all. It's here, it's renal function.
Yeah, that's the most
And
important.
oncocytoma, when it grows, it destroys the kidney and it loses kidney function. So I think the right thing to do is to do the other side as well before it destroys more kidney tissue.
Do we agree with that? That oncocytomas destroy renal function? Do we have scientific evidence for that, or
It grows and replaces kidney tissue. How many oncocytomas do you follow up and it grows and gets bigger? And as it gets bigger, it destroys the kidney function.
So it's not displaced the kidney.
No, it replaces.
So a question to you then, Mr. Mackay, if you have done a small renal mass biopsy and it has shown oncocytoma, would you operate
Yes.
because it's likely to grow and destroy renal
Yes,
function?
to preserve kidney function, yes.
Tony, would you do the same?
No.
Prakash, would you do the same?
No.
So I think we, because of lack of evidence on that, we are likely to do that. So coming back to this case, could I ask you now, Sohail, that probably there are no radiological features. If I come back to MDT and ask you something, by looking at it, do they look similar? Do you think the other side could be oncocytoma?
So as I said, it's on first glance, both of them looked of similar intensity and so on. So if imaging were anything, you could say that the left side looks similar to the right side. The right side is oncocytoma, the left side is also an oncocytoma, but imaging is not histology. So you have to accept that fact that, like Alex said in the first lecture, is that you can have lesions that could be completely benign versus RCC, and they may end up looking the same. So at some point you're going to have to accept that fact that you can't rely on imaging. So the counseling is where you're going to come in and say that, look, this could be oncocytoma, you could leave it alone, or no, what else you wanted to offer.
So suppose we have three options for this patient: surveillance, biopsy, now knowing that was oncocytoma, or surgery. What would you go for? Or I suppose Sabre as well, but he's a fit and well man, so what would you go for?
I would stick to my guns. I would do partial.
You do partial nephrectomy. Turn it.
I'd treat it at face value as a 3 centimetre tumour on the left kidney.
Okay.
you've got that in your mind, it might be an oncocytoma, but it's still a 3 centimetre tumour, I'd do surveillance.
I think it brings, before I say what I'm going to say, it brings a very good important learning point about biopsies in oncocytomas. Histological diagnosis from a biopsy in oncocytoma is a dangerous diagnosis. Okay, and we've had at the QE a recent case, review on that. And it's one of the points that Leo's going to bring out in his presentation this afternoon. So be careful. My worry about this is that neither of those lesions look like an oncocytoma to me.
No.
Yeah, they do look nothing like it, and I've never heard a renal for Bosniak type 4 cyst and an oncocytoma. I've heard of an RCC, but not an oncocytoma. So I would offer, you need ultimate histology, don't we? So it'll be a partial.
Let's got the microphone so people can hear us on the Zoom.
Don't tap the table.
We have a partial nephrectomy, we have a surveillance, we have a partial nephrectomy.
I would do surveillance, but there's one more point I need to kind of ask the panel. And the thing is, if you do a biopsy and it's an oncocytoma in a typical, and also maybe radiologically it's an oncocytoma, do you do a partial nephrectomy after that, or do you just leave it, the oncocytoma? What's the kind of panel?
So the question here, in case you guys have not heard, the question Prof has asked, that if you've done a biopsy and it shows oncocytoma, and your pathologist has very categorically said that this is oncocytoma, what do we do? Do we observe, do we operate, or do we discharge? Is that the question?
Are we bold enough to just leave the patient because of an oncocytoma? In real practice, everybody does an operation on these patients. I'm just asking everybody who's here.
How do we know it's not a hybrid oncocytoma?
So I think the new pathologists are supposed to say oncocytic renal neoplasm, not oncocytoma.
Yes.
And that leaves the door open.
Yep.
So in other words, what I'm trying to say is that oncocytoma is not a benign situation. In management-wise, it'll end up doing whatever you're going to do for this patient.
Sorry, so why are we biopsying anything?
You're right. You're absolutely right. Yeah, it's absolutely right.
So we have two surveillance.
Question there.
Another question, do we have any other imaging at all? I know from AUA guidelines, they do mention about sesame SPECT scan.
So that's
for these.
so that's coming.
Do we use it or?
So I don't think it's coming to the nice things, but SPECT, sesame SPECT, CT, and all
About
is
90% of the
recommended
time
as
they can be diagnostic, so we haven't talked about that.
90% of the time.
Yeah.
Ideally, we'd have done it whilst he's got 2 tumours and compared them.
In that case, we should take out all the prostate because there's no
Just treat. Are you aware of this special technique?
I've heard about it, but I think the evidence is very early, so I can't comment on it.
Okay, sorry.
So I'll stop the side discussions here.
We're just going to, so these are just the biopsies, they're going to be available for everyone to see afterwards. Just to highlight, they do say strong evidence for not performing biopsies in cystic masses, so that's a decision that we've made. And also, as Mr. Batt said, the patient needs to be counselled very carefully regarding positive and negative predictive values of their biopsy.
Okay, so it's a slightly different thing. So it's just a young, fit guy, picture of our horseshoe kidney, and he's got a 1.6 centimetre mass just there on the right side below the hole. So the question here is survey or treat?
Is it the mass there, or is it in the circle? Does the mass look like?
What's in the circle?
Okay.
If you want to have a closer look on the screen here.
And the microphone.
I know the imaging are it's difficult to display the whole.
How old is the patient again?
62.
Sorry? 62. And it's 1 point some.
Speak to the computer. It's not like
I usually tend not to operate on 1.6 centimeter unless it's a solitary kidney. So usually I would say come back in 6 months with another CT scan.
Same.
Same everybody?
Initial surveillance, yeah.
Upesh, same? Rami,
Yes.
same?
If you let it grow, will it make your intervention more difficult, more challenging? You lose more renal tissue, again, the same things come. So
The average growth
these-
rate's about between 2 and 3
True, that is
millimeters
also true.
per year.
Yeah, so yes, I do agree with surveillance, but with caution. You got to put it to the patient that early intervention might have its benefits. We can afford to delay intervention by surveillance, whatever you choose.
Yeah, of course, counselling always in the case, but what I'm trying to pin on everybody is what would MDT recommend? Yeah. So MDT recommendation here seems to be surveillance, am I right?
I'm right.
Yeah. Okay.
Good. Because that's what happened. So after a year, as Mr. Papp sort of indicated, it grew by about 3 millimetres. What are we going to do? What are we going to do at this point?
Is that one scan only after a year, or did he have 2 scans during the year? I'll go back to the increment business. If there's been more than 2 increments in increase in size, that's enough for me. Take it out, because that means that it's cancer.
One of the conversations I have with these patients, not particularly 62-year-olds, 63-year-old now, when they're in their 70s, is asking them when they're planning to die. And that's usually the response, is they laugh at you, well, I'll be happy in 10 years, I'm not going to make it to 80 or whatever. And they'll tell you, and they're quite open about it. They're often quite wrong.
Is that because of you?
They're often actually quite pessimistic. You know, I'll be happy with 5 years. And you think, well, I think you've got 10 years left in you. So this is 3 millimetres in a year, that's 3 centimetres in a decade. So, and these are...
Doesn't work
Got to
like
be
that.
careful about
it does you-
linear and volume growth. It's 3 times.
No, it's cubed.
Yes, so cubed is what I meant, yeah. So
Yes, but
essentially, 3 millimetres difference gets bigger and bigger as they get bigger and bigger.
Almost certainly not.
So I suspect.
So the volume cubes, but the cube root of that almost does equate to your diameter. I've done
You're
the
going to have
maths.
to treat.
It's
You're going to
straight
have to
line.
treat this at some stage.
I suspect what
So
you're
I think
looking
it
at.
will, and I think that needs to be put on the table to the patient and say, what would you like to do? And I think all
I'm the
options are
patient, I
available.
want to live up to 90.
Then treat it with whatever option he wants.
Okay.
Yes, I'll treat it.
I mean, this is one of the situations. So if we decide to treat him, and we waited for some time, and say we give him another 6 months of scan and grows another 3 millimetres or so, then it comes for treating. And this is one of the indications. If we have, I mean, of course, we have to do the proper imaging to say how the blood vessels are, etc., horse kidney for a robotic partial. But equally, this is one of the areas where there is a definite role for a laparoscopic cryotherapy as well. So if you don't want to do, I think this is one of the, I wouldn't say absolute indication, but relative indication with good, because everything is anterior, which to reach in a horseshoe kidney situation for imaging might be a bit different. But if you don't want to kind of dissect it out and have you don't know what the vessels are, you could definitely do a laparoscopic cryo with, of course, with a laparoscopic ultrasound guidance to that you've done properly.
Talking about ablation, Salil, what about ablation in this?
As I said, it's size-wise, it all fits fine. We should be able to get there and reach it. But the location, anterior horseshoe kidney, would make it quite difficult. So as I said, if I would always turn and say, if you have, in this otherwise fit patient, if you have a surgical option, I would say take it. If you say, not really, it's going to be tricky for me as well, I said, well, then I'm happy to have a go.
Hari, would you treat it?
Definitely, we'll treat it. Choice, yes, is lap cryo is a good choice. Partial nephrectomy, very good choice. If my radiologist is happy and patient's happy, microwave or RFA, yeah.
Don't you have your hand in your
I did, yeah. When you're considering a partial as well, non-ischemic for something like this, where you may have 4 or 5 arteries coming into the kidney, non-ischemic's lovely.
We did an angiogram and there were 5 different arteries.
Yeah. You don't have to go for those, you just chop it out with a harmonic, stitch it up, and you lose 500 mils blood. Job done.
So I think the panel is for treatment.
And that's what happened. They had 4 arteries and it was a challenging.
And it turned out
to be an AMR.
One question, whose case is this? Did you do it off clamp?
There was no way to clamp it.
Yeah.
It was not fun.
Okay.
He hasn't got enough clamps.
I have to confess, I was so relieved to see the histology.
Yeah.
Because when you do the off clamp,
Yeah.
you don't have a good vision.
You don't have a good vision.
And if you don't have a good vision,
And also it kind of reiterates the point, isn't it, that small renal tumors less than 3 centimeters, they say, figures are different. Ravi has a different figure. Nearly about 25% of them, 20-25% are benign. So again, it shows the same thing as angiomyolipoma.
This made me wonder whether this was a Gleason 6 prostate cancer. And if you had waited a little bit longer, it would have shown that I'm an AML and leave me alone. But patient anxiety, the size has grown, failed surveillance as far as he was concerned.
Some of the radiological features of the angiomyolipoma you can't see in the
That's when you have fat poor and you can't differentiate.
Because increment is dictated by the frequency of scan. And so if you scan somebody over a period of 2 years, twice, and it grew by 1 millimeter each year, would that be an indication to intervene with the Dell? Because what you're describing is increment. So if something is destined to grow, that doesn't necessarily mean it's destined to be treated. But if you follow your philosophy, which is increment equals treatment equals cancer, so it's contingent on how you scan these things.
I'll share with you the evidence, which is a systematic review. It was done in Canada about 18 months ago. And they found more correlation. It's not a must. Obviously, there were people who had 3 increments, and it was still benign. But they showed more correlation of the number of increments in the increase in size than the actual size differential. So if you had 1 increment of rise, which made it from 2 centimeters to 2.5 centimeter, the chances of cancer are less if the 2.5 centimeter happened over 3 times, provided obviously that the intervals are the same. So you're not just scanning him every day. You have a protocol that you're gonna, for monitoring, you're gonna scan every 6 months or every year. You don't take one single rise in the size as a potential for cancer. You wait until there's 2 or 3 more rises.
You have raised a very valid point, and I don't know what panel members say to their patients when you do surveillance. I always say exactly what Rupesh had said, that they grow, benign tumors grow, and we expect 2 to 3 millimeter size increase in a year's time. So when they know that it has increased, they don't panic. And to be honest, there was, as expected, the size increase was
Can
there.
I ask this panel, I mean, what is the growth you consider as a significant? Because we all know 0.27 to 3 millimeter is the per year growth. So what is the significant growth?
If you are observing somebody with a view to intervene, I would suggest anything that grows 3 millimeter or plus would be taken as a point, given a choice to intervene.
Over how long? Does it matter if it's 3 millimeter over 10 years as opposed to 3 millimeter
per
year? All right, sorry.
So for surveillance of biopsy-proven oncocytomas, 5 millimeter per year is an accepted growth.
Bear in mind that a lot of these don't change. So the ones that don't change, like say, a lot of them don't change. It's the ones that grow with rapid retention. 1 millimeter in the 85-year-old, completely
No, but
different.
taking all those factors together, somebody's young, fit, your surveillance, and so when you say you expect it to grow by 3 millimeter?
I think you can.
No,
It
even
hasn't changed. Otherwise, it's the same argument. Like the cancer would always.
if it doesn't change, it's easy. But what is it when it changes? What is significant?
I think, as Rupesh had mentioned, about 2 to 3 millimeter per year is kind of accepted international literature.
Yeah, it is.
And nobody would be criticized for not following that and accepting that.
The difficulty with this is we get the same scan and measure it on 2 different days.
Yeah.
You'll get more than 3 millimeter difference because, especially if the smaller the tumor, the more difficult it is to measure. Yeah. So 3 millimeters sounds good, but practically it's difficult.
I agree.
I mean, that's why, Adel, your point of velocity of growth is important. If it's constantly growing every time, whatever we measure, that means it's growing, isn't it?
Should we be measuring volume, Salil?
We could, You're right. We could. That's one way to do it. But if you are going to, as a rule, as we do, always give two-dimensional measurements. So you have long axis, short axis, if that's how the lesion is. At the very least, and that's what you would. That's what the RESIST criteria is as well. It is not a volume measurement. It is a long axis, sum of long axis that we measure. So based on that, even if you had, for any lesion, two measurements, that I think is a reasonable idea. So even if you feel a lesion hasn't grown in one axis, but if it has in the other, you can say, well, looks like the volume is grown, and you can make a decision on that at least, you know. But most people, when they do a quick report, they just say, oh, it's 3 centimeter lesion, 3.2 today, and you know, something of that sort.
Can I ask him a question? Given the software that you play with in radiology nowadays,
Yeah.
how easy it is to actually superimpose the pictures one year after the other on each other? Is it possible? Because that's better than usual.
It's
is it bigger or not?
It's only possible. So, for example, it's the exact superimposition is all to do with the technicalities of fusion imaging and the registration of the images.
Yeah.
So, on a different day, a year apart, the patient could have been lying differently, could be slightly off kilt rather than lying straight on the back and so on. So, the moment you suddenly start trying to fuse them, you could have a kidney that's slightly this way or that way.
And you register to the kidney?
You can, but you're increasing every scan reporting by at least 15-20 minutes. And if you start factoring that in with the reporting session, then all you'll have is one report at the end of it.
We need AI.
We need to move on. So
Yeah.
5 more cases.
That case was just presented for highlighting surveillance as an option for people. Let's go on.
So the next case, moving on to our next topic now, which is patients with single kidney. So this is a 7-year-old man, had a radical left nephrectomy in 2014 for an RCC, has been having regular surveillance, and surveillance has shown a new small renal mass in his solitary right kidney. He's got past medical history here, got CKD3, some nephrotic syndrome, and on blood thinners for recurrent GPEs. Here's his scan, CT, showing this.
Can you tell us the rate of growth? Because you've been having serial scans.
I can't show.
Thank you.
I don't. All of the information I've got is on the slide.
Well,
Yeah.
this is a case about, you know, the appropriateness of treatment. So that falls down into the patient and whether you think this is a cancer. Okay, so the cancer decision, if it's not made by that, this is a one where a biopsy would be useful. Okay, and you'll only do a biopsy if you're going to treat him first of all, and that's what he wants. Okay, you've done it, so he obviously wants treatment, and you feel he could have treatment. So grade 2. So now the decision is that going to kill him, or is comorbidities going to kill him, or you intervening? Okay, so that's the discussion really we're talking about.
So the patient 3.7 centimeter, technically higher than 3 centimeter.
Yeah.
Technically higher than 3 centimeters, so risk of metastasis. But I totally agree with your point that whether his comorbidity is going to kill him, whether this will.
And there's the comorbidities, there's also your intervention. So for example, a partial nephrectomy in this guy, okay, 1 in 100 chance of precipitating dialysis, but if he gets dialysis, his longevity is significantly reduced at 78 because, you know, on renal supportive treatment, his life expectancy comes right down. Yeah, comes right down. So yeah.
So who on the panel thinks that this cancer, if we thought it might have been a cancer before biopsy, would kill him within 5 years? No chance.
But can I put the other point? I mean, this patient, if he develops metastatic disease, then he wouldn't be, you know, fit for any systemic treatment. So I think what I showed today, SABRE treatment, which is outpatient-based single non-invasive treatment, if you can deliver that, there is no reason why we can't offer treatment for this patient.
I will come back to the Tony's point. How long are we expecting to live?
Here is my guess, and there is a lot of guessing here. This patient has been under surveillance because he had cancer.
Yes.
So this tumor seems to me to be rapidly growing.
Yes.
And as such, I wouldn't pay any attention to the grade on the biopsy. I would assume that this is a rapidly growing, high-grade disease, and it's particularly easy to do it's hanging fruits.
About to drop off.
Have a
And
drop off,
because
yeah.
of that, I will go straight for an immediate partial nephrectomy.
But Adele, in the first case,
Well,
when the biopsies, you said that you were going to treat because of the biopsy. You did believe in the biopsy grade, and in this one
No,
you're
I
saying you
didn't.
don't believe
No,
in the
I said I
biopsy.
don't
So
believe.
coming back to this
biopsy.
case, one person, one vote for treatment, two vote for surveillance.
I would surveillance for some
Surveillance
time, but I'm
on a
not
treat-
that.
Will treat.
So the patient underwent partial
Yeah,
nephrectomy.
I thought you would
So
have.
high grade T3A RCC
This-
vascular invasion, but next one.
This wasn't actually, the picture I had chosen was not the right choice to show you. This wasn't the hanging fruit.
Okay.
You can't tell them.
It's just one way to look at it, but it was.
But
going-
it emphasized the point I was making. The biopsy grading is very unreliable.
Yeah. So it was more high grade disease, and that brings us to the point that many times small neural masses may not be that
That benign.
that
in inverted
benign.
commas.
But having said that, still, I will come back to Tony's point.
Will it kill him in 5 years?
Can I come
No.
back to that same patient because he had lots of comorbidity, so I assume that patient is not for surgery. Obviously, he had partial nephrectomy. Saber would be if patient is not for surgery because to preserve the renal function, because the other alternative for this patient is either wait to develop systemic disease, metastasis, or lose the kidney. So either of those are not good choices.
So how is his EGFR and all that? Is it post-operative? Is he okay? Dialysis
Yep.
dependent?
No.
Yep, yep.
He I think he went home in 3 days.
Okay.
He didn't need dialysis. His renal function dropped a little, but not much.
You did not consider ablation for him?
No, I didn't.
Okay.
Because I think I was going to come back to this point that if he was wanting treatment after counseling, which many people do because they've had cancer before, I have a feeling, I don't know, I'm maybe speaking on behalf of the panel, we may all have thought of ablation as a
I
first
think
step.
it is definitely a choice. I can't remember why I didn't.
Derek?
I was just going to ask, in terms of the panel, generally when you either counsel patients or discuss them or MDT, I know we use performance stats a lot. Does anybody routinely use something like the Charleston Comorbidity Index? Because in terms of what Mr. Baker, about how long we likely to hang on living, there's a lot of evidence showing that actually the risk of morbidity from competing comorbidities is very high. A lot of the patients still find it liver mass disease, especially if they're over 70. Isn't that more useful when counselling a patient than their performance status? Because performance status is just a number in terms of what they can do day by day. If they've got a 50% chance of dying in the next 5 years just from their other comorbidities, are you doing them a service by? And I think isn't that a more useful context?
So the question you're asking is whether any of you use the comorbidity index.
Because they mentioned
Does anybody use it?
So as I said, for all our patients, the SABRE data we just showed, we have Charleston Comorbidity Index. That is useful just to the extent that you're selecting your patients rightly, that you're not denying them surgery. That's all it is. But you have to take all those things together because Charleston Comorbidity Index gives you a 10-year survival, 5-year survival. It doesn't tell you what's going to happen in the next 3 years.
What I'm saying is, before offering surgery or telling people, should I be offering you surgery or not? Does anybody actually use that? Because I think it's quite, because when you talk, it's very easy to speak to an 86-year-old and say, look, I don't think I'm going to increase your life expectancy by doing an operation. But all these people in their 70s or early 80s who were actually fairly fit, I think it's more useful to have some sort of figures.
Chris?
What about
use the Charleston Comorbidity. If you're in your 80s, it's 10 life year, just by that.
Just by the
zero,
zero.
Your 10-year survival at 85 is 0%. Clearly, there are 95-year-olds walking around.
Yeah.
But that's a statistical thing. In your 70s, if you had that, and then minor heart attack, 4%, 10-year survival rate is 0. So 75-year-old heart attack is stent is 0, because you get onto your decades. So quickly, as well as 90, 80.
Okay, I think we got the message. The message is whether your operation is going to make them live longer or make them live shorter.
That's useful. If you don't think it's a useful tool, then so the answer is no. But for that reason, because actually you think it overestimates the mortality.
What are you gonna do? Point taken.
Okay, so this is a similar theme, but a slightly different case. So again, she's had she's 75 years old, she's pretty frail, COPD, and she's had a kidney out for cancer. So she's got a scan for anemia. The single kidney's got a 4 centimetre mass in the lower pole, there's no distant disease on the scan, and she's been biopsied, it's clear cell. What are the panel's thoughts about what we're doing with this patient?
A fairly similar sort of case, solitary kidney, biopsy proven, nephrectomy on the other side before.
This looks a little more complex. I mean, I know you didn't show all the pictures from the last one. So it's going to the renal sinus. So here again, I think ablation would be a more option, because radical nephrectomy, partial nephrectomy is quite difficult. And maybe that might be a much better option for her. I mean, if she's going for surgery, if you're going to do surveillance, that's possible.
I would certainly advocate an open partial nephrectomy is called ischemia.
How many people, can I, sorry?
Yeah, no. Yeah, go on.
How many people in the panel who do partial nephrectomies would appreciate 3D imaging for this, for surgical planning?
I would appreciate an angiogram, and I always study obviously the blood supply.
Good question.
I'd just say there's a bit of under usage of ablation and saber, because she's 76, quite frail, with a biopsy proof RCC. I would be very, very reluctant to being formed surgery. There is less invasive options available with similar
Absolutely right.
So my feeling, the most important bit of this presentation is the word frail. That's a really good reason to not go jumping in there and to take 6 months. Do another scan. This has been, I don't know when her previous scan was last. She's had surveillance for a period of time, presumably since 2007.
So
But
6
was that
months.
after 5 years, or was that after 10 years? We don't know when the interval there. So we don't know how quickly it's growing at 75, and she's
So 6
frail.
months
Frail is a
that you're-
big
6
negative.
months you're waiting with a tumor with sinus invasion. Are you
Yeah.
going to buy her a gym membership?
Frailty spectrum.
If she's got Mets in 6 months, they're already present now.
So frailty spectrum is quite wide, isn't it? I know it says frail. She wasn't that frail that not fit for treatment, and she did not really wanted to, even 0.5 or 1% chance of losing kidney function and going on dialysis. So she decided to have ablation.
I suppose this is the area to have ablations.
Yeah, perfectly placed.
What was the size of the tumor again?
4 centimeters.
So she did well initially, so follow-up after about a year was clear, and then she started bleeding after about 16 months. And the follow-up scan showed that she's got a possible recurrence just adjacent to the previous ablation site. So where do we go from here?
Repeat it.
I know where we did go from here, but
What's your GFR now?
About 48, 49.
Yeah.
I'll do exactly the same that I would have done 16 months before.
we could retreat. We
I'll
offered,
do an open
but she didn't get that.
partial nephrectomy
She
with
was
cold ischemia.
she was offered out options.
So I think, she would be a safer candidate again,
I was going to ask, would you accept her for Sabre who has had ablation?
Yeah, it's a cancer.
Can I ask how you counsel them with Sabre? As excited as I am with your presentation today, I think it's, dare I say, the best presentation today. But how do you counsel the patient? Do you actually tell them that this is still an experimental treatment that we don't know?
So
Or do we put it on equal par with open
as I said to
or
you,
partials?
as I said to you, the data I showed, all the patients had counseling, and all patients fit the criteria. The criteria itself is that they are not fit for surgery.
But she
So,
is fit for surgery.
So
But that's the problem.
Okay, we're all trying to do the right thing by this patient.
Yes.
We're all on one team. We've got different modalities
Yes.
to treat this
Yeah,
patient.
but it's nice to know that different options are available. That is the purpose of the MDT, rather than actually
Is that how we do it?
Yeah, there are differences of opinion, there are differences in counselling, and differences what patients want to pursue. And it's very nice to know that Sabre as an option is available. One question I wanted to ask, she is now having hematuria, and that's where we had concern. She was coming in repeatedly, so we were wondering whether it's going into the clinician system. Would your Sabre stop something like that? Do you know?
I think I haven't had any patient who's had hematuria, I have to be honest, so I don't know.
So we don't know.
I mean, normally radiotherapy stops bleeding.
Yeah,
That
okay.
maybe.
Is there any hands up there? Anything important you want to raise? Yeah.
Just wanted to ask, would you prefer redoing RFA versus Sabre, or would you just opt for Sabre, and if only for Sabre, why?
No, I think if she has an invasive option ablation, that is fine too. I think, it's just one of the options.
I mean, from what I remember, this patient, sorry Anjali, what I remember this patient is that nothing had changed in the patient's overall status between the last ablation and this one. We frequently do re-ablate recurrences, not frequently, pretty much all the time. So we had offered, but obviously the course changed, which Anurag pointed.
We were reconsidering re-ablation actually, and she was keen for that, but then she started having hematuria. And then she said, you know what, I had enough. Just take my kidney.
Whole kidney.
Embolization?
We did consider that, but still don't want
It's got a radical effect.
Can I ask
So
one
that is-
question for my full learning? For patients who have hematuria, if you do ablate them again, will the hematuria stop?
Yes, again, ablation with heat modalities are again hemostatic, but the fact that they are bleeding makes you wonder that there's already invasion happened into the pelvic LACL system, so you may not be able to achieve the same curative ablation. So you're now talking about symptom control rather than curative treatment. So that's where.
Okay. So last case.
Sorry. With retrospectoscope now, would she have been better off with a partial nephrectomy at the outset?
Quite possible.
Thank you.
Quite possible. Have you had partial nephrectomy in patients who have recurred?
Once over the last
We all
20
have.
years.
We all have.
Yeah.
Put hands on our heart and we know.
Once over the last 20 years.
So this is not a point to make that ablation is
No.
a bad treatment. Ablation works very well. This is one of the cases where ablations have recurred. And she could have been very well re-ablated in that situation. So yes, in retrospect, we can say a lot of things because that's the best scope we have. Let's move to the last case.
So, moving on, this is a 75-year-old gentleman. He had a laparoscopic partial nephrectomy back in 2016. Also had some treatment for prostate cancer, and also developed a bladder TCC in 2018. Past medical history is minimal, but baseline GFR is relatively low at 59. After his partial nephrectomy, we had surveillance. And here we've got annual scans from 2018, 2019, 2020 showing an increasing size solid mass at the previous resection site. So my question to the panel is what people's thoughts about further investigations or immediate treatment for this patient. Does anyone particularly have concerns about history of TCC?
Do we know whether that partial nephrectomy done in 2016 was positive margin,
Negative margin.
Negative margin.
And that was done in Liverpool.
So I suppose the issue here is whether this is a recurrence from the previous partial nephrectomy. Is that what's going to everybody's mind?
Yeah.
I mean, the other kidney is fine, isn't it?
Not very good.
So
Not very
baseline GFR
A bit lumpy.
59.
And small.
Lumpy means tumor.
Based
So you've
on
got a differential
GFR
lumpy.
Baseline GFR 59, straight function equal.
More or less, yeah. 44.
Yeah. 44, 56.
On the other side, this is 56.
And I think we'll.
Your
I don't know,
differentials
I'll-
are between a TCC or an RCC or a TCC, aren't they?
That's
Even though it's a low grade. And I think the morbidity of a ureteroscopic examination is quite low. So I would have a low threshold for a ureteroscope.
Ureteroscopy biopsy.
Went on to have a CT urogram, urine cytology sent. The CT urogram don't think gives us any more clarity as to what we're looking at necessarily. The ureteroscopy showed impression of a mass indenting into the collecting system, and biopsy showed no cancer, nor mucosa.
And I guess ureteroscopy did not show any papillary lesion.
No. Normal mucosa on the outside.
So where do we go now?
So isn't it likely that this is a recurrent RCC?
Yes.
Yeah.
I would go for
I would-
Correct. So,
Yeah. I mean, with the growing size like you've shown on this on the CT scan,
Yes.
even though the biopsy shows no, I would lean towards this being a recurrence, local
Correct.
recurrence.
So we all biopsy it now?
Yeah, I would.
you've done a biopsy, have you?
No, that's the
This is
that's
the
the
uteroscopic
uteroscopic
biopsy.
biopsy.
Yeah.
Yeah.
He then did go on to have an ultrasound
Yeah, okay.
which was not diagnosed.
Sorry.
Yeah.
So what do we do now?
CT guided biopsy.
Well, that's not available in the centre.
It is.
This is the information we've got to go on for this patient. So what?
So again, why was it non-diagnostic? You know, I know I was being a bit facetious there, but you know, why was it? Did we hit
Sally's
other?
hand was shaking that way. How was it?
Cyril didn't do it. He
Well, that's
was
real
being
work, isn't it?
diagnostic.
So
would you
what
consider
happened? This was actually in January.
Well, that's
and
the
I
question.
actually had planned for him to have a biopsy and ablation at the same sitting. At this point, and our MDT said no. So he went to our ablationist, and I trust his biopsies, and he went and he biopsied it first with a view to bring him back to ablation. So I trust the biopsy.
That's okay, fine. Well,
And it was
that's really
non-diagnostic.
important. That is important.
So
If it's somebody you
what
trust,
would
then
you
yeah.
do in this situation now, Mr. This is
It's difficult. Biopsy didn't give the answer.
but the lesion has been increasing progressively over the period of 3 years.
Yeah.
And it's now we have more of this
And,
proven it's not
can
PCC.
I just say, how old is he?
72.
And the ASA, 3?
No, he's fit now.
Fit and well.
Performance
Uh,
is,
I'll do an open partial nephrectomy on him
Open partial.
with cold ischemia. The renal function is of the essence here, and
59.
this is increasing in size.
Yeah,
The sooner I operate, the more I can
Open partial nephrectomy.
preserve kidney function.
I wouldn't ask Tony because it's Tony's case.
although he has had another CT at this point, and it's rapidly grown by almost a centimetre over
So it's grown,
a year.
grown even more. Grown even more. The patient.
I'd ask for my colleagues regarding ablation.
I would happily accept ablation.
Yeah, so ablation is one choice, open partial.
He's 59, isn't he?
How
No,
old
no,
is he?
that's his GFR.
That's his GFR.
He's 72. He's 72.
75.
75. Then I'll do again ablation.
75. But a good 75.
Ablation. Tony,
I would lean towards ablation because it's an endophytic tumor involving the hilum. Even ultrasound guided partial would be difficult. So I would, if it can be satisfactorily ablated, I would go for that.
So I was still not happy this wasn't TCC. This is pushing right into the collecting system. It's distorting the collecting system. You can see kidney on the outside of that, where the previous partial was. I'm not happy this isn't TCC.
So a referral was made to Oxford for consideration of bench dissection. They recommended an MRI, which was performed, which didn't change very much.
So this idea of the bench dissection is so that if this is TCC, they can take it out of the body, extracorporeally, take it out, do a frozen section, TCC, throw it away. If it's RCC, you can put it back in again.
Well,
in a
this
safe
is-
way.
this
I
is
wouldn't
where
do
I'm
that
going
as
to bring
a-
a point in here that I think we all are kidney surgeons here. I think gone a little bit too far, and this may be just my impression. We just partial is ingrained in our head,
Yeah.
and we forget that sometimes radical nephrectomy may be a very straightforward, clear.
This is his
solution.
better kidney.
Yeah, so a 75-year-old with GFR of 30, 35, carried on living a reasonably normal life.
He's looking at
Again,
20.
there is thing, isn't it? After 66, it's
And-
pretty
and-
sure partial. That's
And only randomized trial for partial versus radical, admittedly has got lots of biases in it, has proven that radical nephrectomy is no worse than partial nephrectomy. And sometimes we go over and beyond trying to preserve kidney.
What would you do then?
I would have done a nephrectomy.
Particularly
Actually, to be honest,
true.
I've offered to this patient right at the beginning, biopsy or no biopsy, whether you want a nephrectomy or a nephrectomy, because it may be TCC, and you're done with in one go, done.
I would particularly support Anurag's viewpoint here because of the point of hilar tumors. If
also-
hilar tumors you try and remove by partial nephrectomy, how much kidney function we lose?
I support that point because it's already a recurrence. So it's a recurrent tumor.
Yeah.
So it's a tumor has come back. So we're trying to preserve and preserve and preserve. And I take the other kidneys.
The
very
only
small.
thing I will say, it's not either or. Everyone, although I've only converted one partial into total in my career so far, but every one of my patients is told, if it's not possible, if I'm not going to leave you with a viable kidney tissue and do a total. So I don't think it's either or. Keep your options open. If you're there and you can preserve half of the kidney, a third of the kidney, to keep his GFR at 40 rather than 20, then take it up. That's fine.
So I think we've eaten a lot into lunchtime. We'll talk about the lunchtime.
He had a radical.
We're only about 10 minutes into the lunch.
And it was
I hope what we've done for them is trying to decide.
It was an RCC.
Yeah.
You don't observe surveillance, you don't observe surgery, etc. We can carry on the discussion.
I really agonised over that.
Thank you.
Guys, can I have your attention for a minute?